Okay, I think we can get started with today's presentations. My name is Ed Hallrott. I'm the program coordinator for Advance-CTR, and I'm substituting today for Sharon Rounds, the PI, who is on a study section today, important activity. It's my pleasure to introduce today's two speakers who are current awardees of pilot projects. And we'll kick off first with Dr. Nicole James, who received her PhD from the University of Rhode Island in pharmaceutical sciences, did a postdoc at Women and Infants Hospital, and is now an assistant professor of OBGYN and associate research scientist at Women and Infants Hospital. And as you can see from the title slide, she will be presenting her work on unraveling the unique ovarian tumor immune microenvironment to uncover novel prognostic and therapeutic targets in high-grade serous ovarian cancer. Please, as you follow along, if you have any questions, please place them into the chat so that we can cover those in the Q&A period. Dr. James, it's all yours.
Good afternoon, and thank you so much for the opportunity to present. So my lab primarily focuses on ovarian cancer, which is the most lethal of all gynecologic malignancies. And the primary or most common histology in ovarian cancer is high-grade serous, which represents about 70% of all cases. And in the United States alone, there's approximately 20,000 new diagnoses of ovarian cancer yearly and about 14,000 deaths attributed to the disease. And the 5-year survival rate for ovarian cancer is quite low at only 49%. And unfortunately, this statistic has really not improved within the past decade or so. And one of the reasons for the low 5-year survival rate is that ovarian cancer is frequently detected at an advanced stage, most commonly stage 3C, where cancer is already present in the lymph nodes and has spread to distant regions within the abdomen. And second is the eventual development of chemoresistance. So while high-grade serous ovarian cancer patients typically respond well to a frontline treatment regimen that includes platinum and taxane-based chemotherapy and interval debulking surgery, about 80 to 90% of patients initially achieve remission. However, within 12 to 18 months following remission, the majority of patients develop a recurrence, at which point the patient's tumor is no longer responsive to traditional chemotherapeutic approaches. And there has been a concerted effort to develop novel targeted therapies. Two of the most successful have been angiogenic inhibitors such as bevacizumab and PARP inhibitors such as olaparib, and these have been initiated in the maintenance setting for patients, and they've really only modestly improved progression-free survival. And with the exception of BRCA mutated patients and olaparib, there really hasn't been a significant improvement on the overall survival rates. However, in recent years, some of the most successful targeted therapies are immunotherapies, which have really revolutionized the field of oncology. In ovarian cancer is no exception. Immunotherapy has been heavily studied, particularly the most famous immunotherapy, PD-1-based immune checkpoint inhibitors. And PD-1 is a T-cell receptor, and when it binds to its ligand PD-L1, which is overexpressed in tumor cells, this sends a strong apoptotic signal to the T-cell, so it's no longer able to infiltrate and promote tumor cell death. However, with a monoclonal antibody against PD-1, we're able to block the PD-1, PD-L1 access, so the T-cell is able to stay activated, facilitate immune attack, and cause tumor cell death. However, clinical trial results have really demonstrated that response rates for PD-1 based monotherapies are quite low, so they're somewhere between 10 and 15%. And unfortunately, when we look at PD-1 combinatorial therapy with standard of care chemotherapy, as well as with some of those maintenance drugs like olaparib and bevacizumab, we don't see an improvement in PD-1 response rates. So why is high-grade serous ovarian cancer so unresponsive to clinically utilized immunotherapies? So we traditionally think of why a cancer subtype responds well to immunotherapy. We think of its tumor immune microenvironment. So different cancer subtypes can be classified as having a cold or a hot tumor immune microenvironment. And an example of a cold tumor microenvironment would be pancreatic cancer, where there's a vast exclusion of cytotoxic lymphocytes from the tumor immune microenvironment with a higher proportion of immunosuppressive cells like Tregs. And when we contrast that to a hot tumor like melanoma and non-small cell lung, and these are cancers that respond really well to PD-1 based immunotherapy, they have a high proportion of CD8 positive T cells and NK cells, so cytotoxic lymphocytes present in their tumor, with a much lower level of immunosuppressive cells. However, ovarian cancer doesn't neatly fall into these two boxes, and it can be best described as having a warm tumor immune microenvironment. So indeed, cytotoxic lymphocytes are present, but when we compare to a hot tumor microenvironment, there's a much higher level of immunosuppressive subsets like Tregs. And also just naturally where ovarian cancer metastasizes within the peritoneum, there's a high degree of adipose tissue, which is naturally immunosuppressive, as well as the ovarian tumor microenvironment has a high degree of cancer-associated fibroblasts, which can directly stimulate angiogenesis. However, despite this fact, we know that intramural T cells are highly prognostic in ovarian cancer. And this graph is from a seminal study published in the New England Journal of Medicine 2 decades ago. And what it shows is quite strikingly that patients that have higher levels of intratumoral T cells have a significantly longer progression-free and overall survival. And these results have been recapitulated many times in large meta-analyses. So we know that intratumoral T cells are important prognostic factors in ovarian cancer. So despite the fact that ovarian cancer does not respond well to clinically available immunotherapies, we know that ovarian cancer is an immune responsive cancer. So our lab really wanted to better understand the uniqueness of the ovarian tumor microenvironment. And we were initially thinking as to how to tackle this question. We wanted to see if there were more prognostic relevant immune receptors in high-grade serous ovarian cancer. So thinking beyond the PD-1, PD-L1 pathway. And to look at this initially, we performed an RNA sequencing-based assay, and we looked at 29 high-grade serous treatment-naive tumor samples, and they were sequenced for 30 of the most commonly studied immune receptors and ligands. And what we found was that significantly higher levels of the immune checkpoint receptors, LAG3, CTLA4, and PD-1, as well as the immune co-stimulatory receptor, ICOS, were significantly associated with improved overall survival. And initially, this seemed quite odd that an immune checkpoint receptors would be associated with improved prognosis. But this actually is a phenomenon that's been well documented in immune oncology. And although the precise mechanism is not known, the idea is that patients that have a more robust immune response have compensatory mechanisms in place that keep cytotoxic responses in check. And I should mention that when we looked at total immune infiltrate in these patients, that did not correlate or have an association with improved prognosis. So these individual immune receptors are individually prognostic, although we definitely suspect some type of compensatory mechanism is occurring. And so one of the limitations of this study was that it was in a small sample size, so we wanted to validate the prognostic capabilities of these immune receptors in a larger cohort. So to do that, we employed TCGA data in an ovarian cancer serous cohort, and this was a cohort of over 300 patients. And we see that in this expanded population that only levels of LAG3 and ICOS validated, so higher levels of each again, were significantly associated with improved overall survival. So continuing to test the prognostic availability of these intratumoral immune receptors, for a prognostic factor that really have ultimate clinical utility, we really want to be able to detect this in non-invasive means for patients. And levels of immune receptors have circulating levels have been tested in other cancers, but they hadn't in ovarian cancer up until this point. So we wanted to see if these two immune receptors were prognostic in patient serum. So to perform this study, we were fortunate enough to get 75 treatment-naive high-grade serous patient serums that we were able to obtain through the Department of Special Testing at Women Infants Hospital and our program in Women's Oncology Gynecologic Tissue Bank. And so we tested for ICOS and LAG-3, or they were the two of the most prognostic intratumorally, as well as PD-1 as a control, since it's the most commonly studied immunotherapy, but only PD-1 and LAG-3 were detectable. And then also simultaneously, we wanted to look at a broad array of immune factors to see how they related to high-grade serous ovarian cancer prognosis. So we also employed a 48-plex cytokine and chemokine panel. And our results quite strikingly showed that LAG-3 with higher levels of circulating LAG-3 were significantly associated with overall survival in patients. And that was when we stratified by median and upper and lower quartile levels. And then we also saw that serum LAG-3 was significantly associated with progression-free survival. And for this analysis, the progression-free subgroups were stratified according to clinically relevant cutoffs. So we had patients that have a lower than average progression-free survival of less than 12 months, an average progression-free survival of 12 to 18 months, and a greater than average progression-free survival of over 18 months. And we saw that circulating LAG-3 was significantly correlated with improved prognosis. So like we see intratumorally, also in serum LAG-3 is highly prognostic. And when we compare this with PD-1, we see that levels of circulating PD-1 are not prognostic, so they're not associated with overall survival when stratified by median and upper and lower quartile levels. And similarly, we detected no relationship with PD-1 and progression-free survival. So this again recapitulates what we see intratumorally, that LAG-3 has superior prognostic capabilities in ovarian cancer. And then for our multiplex serum analysis, we did find, although not strikingly, that the pro-inflammatory cytokine IL-15, which is responsible for NK cell activation, was inversely correlated with progression-free survival. However, we did not detect a relationship with IL-15 and overall survival. And initially, we found our multiplex serum analysis to be quite disappointing, as we did not see many cytokines and chemokines related to prognosis in high-grade serous ovarian cancer, although I really think it points to the strength and the prognostic relevance of LAG-3 specifically in ovarian cancer. And the conclusions from this study show that despite ovarian cancer patients not responding well to clinically available immunotherapies, that immunological signatures are related to patient outcomes, and they can be detected through non-invasive means. And this prognostic relevance of LAG-3 is especially timely because as of last year, there's been a total of 97 clinical trials initiated, many in the early phase 1-2 development, looking at different LAG-3 inhibitors. And in ovarian cancer cohorts, it's looking at targeting LAG-3 in combination with PD-1 based immunotherapy. So results from these trials are highly anticipated. And future directions on our end involve examining how secreted levels of LAG-3 change throughout a patient's treatment course and at recurrence. So moving on in our quest to better understand the uniqueness of the high-grade serous ovarian cancer tumor immune microenvironment, we know that the majority of patients respond well to frontline chemotherapy. So that is not going away anytime soon. So we wanted to see how the tumor immune microenvironment adapts following standard of care chemotherapy and what mechanisms exist that underlie these adaptations. And if chemotherapy-induced immune changes contribute at all to the development of chemoresistance, with the idea of leveraging these natural adaptations that occur to hopefully identify novel immune-based targets that better recapitulate the uniqueness of the ovarian tumor microenvironment. So to do this, we employed a nanostring pan-cancer IL-360 analysis, which looks at 770 of the top immuno-oncology genes. And for this analysis, we had 31 matched pre and post neoadjuvant chemotherapy high-grade serous tumor samples that we obtained at the patient's diagnostic biopsy, and then at their interval debulking surgery following at least 4 cycles of chemotherapy. And we did see a host of immunotranscriptomic changes in response to chemotherapy that were either upregulated or downregulated in post-neoadjuvant chemotherapy treated tumors. But for the sake of time today, I'm going to talk about one of the genes that was most prominently upregulated, AREG, also known as amphiregulin, which is a low affinity EGFR ligand. And the reason we were so interested in AREG is that a lot is known in its role in cancer and classical immunity. So AREG is known to promote cell proliferation, metastases, and specifically drive the epithelial to mesenchymal transition in cancer cells, as well as in classical immunity. It's thought to function as a type 2 cytokine, which downregulates adaptive immunity and promotes immunosuppression. So despite the fact that a lot is known on AREG up in cancer and classical immunity, there's not that much known about how it affects the tumor immune microenvironment, specifically the ovarian tumor microenvironment, which we were interested in exploring. And when we look at publicly available data, we see that AREG is not prognostically associated with improved progression for your overall survival. But interestingly, in the TCGA cohort, we see that AREG is significantly upregulated in platinum-resistant tumors. And these are the small subset of patients that don't respond well to frontline therapy. So they have an exceptionally short progression-free survival of 6 months or less. So we see that in patient tumors, AREG seems to be associated with chemoresistance. And so when we were initially tackling how to better understand how AREG affects the ovarian tumor immune microenvironment, we wanted to mimic the increase in AREG that's seen clinically following neoadjuvant chemotherapy exposure. So we treated the high-grade serous ovarian cancer cell line OVCAR-8 with recombinant AREG and subjected these cells to nanostring analysis again to look at tumor-intrinsic immune changes. And we found a host of genes that were upregulated following recombinant AREG expression that all seem to drive ovarian pathogenesis. So we have CXCL8, IL-8, which is a major angiogenic cytokine, EGR1, which is involved in chemoresistance, LIF and IL-11 are IL-6 associated cytokines, as well as CXCL1 and CXCL2, which are overexpressed in ovarian cancer and promote tumor suppressor macrophage recruitment while simultaneously blocking cytotoxic lymphocyte accumulation. And at the pathway level, you can appreciate the pro-tumorigenic changes. So there's an increase in genes that are driving tumor immune evasion. Specifically, when we look at the cytokines, these are largely immunosuppressive chemokines and cytokines, as well as an increase in cell growth pathways like Wnt, MAP kinase, and the STAT pathway. And so we validated some of these differentially expressed genes in an additional high-grade serous cell line P1 and found that a lot of these genes validated in a second cell line. And then we also used TCGA data to see if any of these differentially expressed genes correlated with AREG levels in human samples. And we found that 3 of the differentially expressed genes were some of the top genes that correlated with AREG, so adding a degree of clinical relevance to our nanostring findings. And then we also employed a commercially available phosphoproteome profiler to see how different cell growth pathways were affected by recombinant AREG, and we found that in both high-grade serous cell lines that phosphostat-3 signaling was upregulated, and we validated this by Western blot, and we also saw that PDL1, which is downstream of the STAT3 pathway, was also upregulated following recombinant AREG exposure. And then we also want to look at secreted levels of IL-6 as it's a major STAT3 cytokine, and you can see that as prolonged exposure to recombinant AREG increases secreted IL-6 levels in a stepwise fashion. And so up until this point, we had only looked at tumor intrinsic immune changes. So we wanted to look at in vitro how AREG is promoting immune cell function. So we specifically looked at recombinant AREG's effect on peripheral blood mononuclear cells. And to do this, we performed a co-culture with our high-grade serous cells and PBMCs. And so these co-cultures were stimulated with or without recombinant AREG. And interestingly, we see when co-cultures are treated with recombinant AREG, this leads to a higher cell viability in the tumor cells. So it's suggesting that the presence of recombinant AREG is preventing perhaps PBMC's ability to infiltrate and kill the tumor cells. And then interestingly, when we treat just PBMCs with recombinant AREG, we see a significant decrease in the major pro-inflammatory cytokine interferon gamma, which is really required to potentiate cytotoxic immune responses. And then finally, we also examined the effects of enhanced AREG exposure in vivo. So we used an ID8P53 null C57 Black 6 model. So these tumor cells were injected IP, and once tumors were allowed to form, we treated daily with recombinant AREG until the time of euthanasia upon large ascites formation. So serum and ascites were collected for cytokine and chemokine analysis, and then we also collected tumors to look at previously identified genes from our nanostring analysis, as well as looking at immune infiltrate. And so just for the sake of time, I'm going to briefly go over some of our initial cytokine and chemokine results, drawing your attention to our IL-2 results. So we did see an increase in both pro and anti-inflammatory cytokines, but most importantly, IL-2, like interferon gamma, is a major pro-inflammatory cytokine, and it's actually originally called the T cell growth factor. And this is really clinically timely. So it's been tried to be developed as immunotherapy for years, but due to the fact that it's such a potent and important cytokine, one of the major challenges has been systemic toxicity, but just this year, Women and Infants is one of 3 sites to participate in the phase 1 Avenge Bio trial, which is looking at a lipid encapsulated IL-2, which is given through local peritoneal administration to try to lower that systemic toxicity. So it was interesting to us that AREG is affecting such a clinically important cytokine. And then also briefly, we see that the mice treated with recombinant AREG have a reduction in cytotoxic CD8 positive T cells, and also a higher level mice treated with recombinant AREG have an increase in intratumoral PD-L1 levels. So this recapitulates what we see in our in vitro high-grade serous lines. So the key takeaway is despite the lack of patient response to currently clinically available immunotherapies, we know that specific immunofactors are prognostic in ovarian cancer, and we've demonstrated that there are measurable immune changes that form from standard of care chemotherapy. And ultimately, these translational profiling studies represent the first step in really unraveling the complex ovarian tumor microenvironment and can serve as jumping off points to evaluate novel immune-based targets like AREG. And I just want to thank the program in Women's Oncology, my lab collaborators, and my funding sources, specifically Advance-CTR. And with that, I'd be happy to take any questions.
Thank you, Dr. James. While we see if any questions show up in the chat, if I could ask you one. With regards to the prognostic indicator LAG3, briefly, what's known about LAG3 in terms of its mechanism of action or functionality in vivo?
It's an immune checkpoint receptor. So it is also a T cell receptor, like PD-1. It's just not as prevalent on cytotoxic T cells, and it's also present on NK cells, making it a more encompassing target. So I think that's why people are interested in it. And also, it's more heavily expressed on like terminally exhausted T cells. So that it's really forthcoming, right? It's really the next big immune checkpoint therapy. There's a lot of clinical research being done on it. So those.
Yeah, you mentioned a large number of clinical trials and
Yeah.
going now, so terrific.
Yeah, it's being tested in many different solid tumor cohorts.
And maybe another just quick technical question. The AREG, the studies that you did were performing with the recombinant AREG, are there any differences between the recombinant form and the natural form of AREG?
So that's something that we definitely, need to investigate further, because we've only looked at, the recombinant AREG exposure, just trying to mimic, in vitro, the increase in AREG that we see clinically in the tumors. So we haven't investigated specifically how that differs compared to patients that are exposed to chemotherapy, in an in vitro system.
Right.
Or in vivo system.
Maybe following on that, so the nanostring is obviously looking at RNA expression. What's known about the protein expression levels? Anything?
So for the sake of time, I didn't show that, but that was in the paper too. We validated AREG at the protein level, and that was also upregulated in patient tumors. So we had those same FFP samples, and we used IHC staining. So we did so it is upregulated at the protein level as well.
Right. So don't see any other questions in the chat. I think we just have a couple minutes remaining, so if you have questions out there, please enter them in now, or get in touch with Dr. James afterwards. Yes. Okay, so maybe we'll any final comments, Dr. James? Last 2 minutes.
Thank you so much for the opportunity to present.
Okay. Well, we look forward to your work, and please let us know if there's anything else that we can do to help advance your work and your career.
Thank you so much.
Okay. All right. So with that, maybe we'll shift over to the initial title slide for Dr. Goedel. And let me introduce William Goedel. Will is a assistant professor in the Department of Epidemiology at Brown University School of Public Health. He's a social epidemiologist whose work includes understanding how policies and practices in housing, education, and labor shape the conditions of neighborhoods, and how these conditions in turn impact health of the residents. So he was very much involved in studies, including the Rhode Island Department of Health during the recent COVID pandemic. And so we're looking forward to hearing more of the work that he has pursued. And the title of his talk is Using Data Linkage to Describe Occupational Patterns in COVID-19 Vaccine Uptake. Will?
Hi, everyone. Thank you for that fantastic introduction. I'm really happy to be here with you all today to present my work that was funded by one of our Advance-CTR pilot awards over the last year. I'm here to talk about what we can learn when we're able to link together multiple administrative data sources to inform our public health promotion efforts. And I'll set the stage at least to say that while we've all experienced the COVID pandemic over the last 3 years to varying extents, it has not impacted us all the same. My work is really grounded in the premise that structural racism and other forms of oppression are fundamental causes of COVID-19 related health disparities, in that the profound segregation of neighborhood schools and workplaces created and enforced by centuries of systemic racism in our laws and policies and practices is really a fundamental cause of our health disparities. It's the reason why some people are overexposed or more disproportionately exposed to SARS-CoV-2, the virus that causes COVID. It's the reason why they may seek care later or go undiagnosed or not get treatment that may reduce the severity of their illness. It's also one of the fundamental drivers of why the way our society is structured is why people have not taken up effective vaccines at high levels in the way that they might want to. In Rhode Island, really, the burden of the COVID pandemic has fallen pretty squarely, disproportionately on Black, African American, and Hispanic Latino Rhode Islanders, as evidenced by this graph here from the Rhode Island Department of Health, which shows age-adjusted rates of COVID-19 hospital administration by a year over the last 3-ish years of the pandemic, really showing in particular in the third bar in each of these groups, Latino Rhode Islanders are perhaps at the highest risk of hospitalization and other severe outcomes here in Rhode Island. With that said, the COVID pandemic really has seen kind of unprecedented scientific progress in being able to address a novel pathogen. We went from having a complete genetic sequence for COVID within days of the first cluster of cases of pneumonia of unknown origin by the scientists in the People's Republic of China to the WHO, to having effective vaccines approved for emergency use in under 12 months, which really astonished many, many people. These figures here are both from the New England Journal articles that described the primary results, the early results of the phase 3 trials from Moderna and Pfizer BioNTech's mRNA-based vaccines. And I think at this stage, we can generally all agree that vaccines are highly effective in reducing the risk of severe outcomes related to COVID, but they both require high levels of uptake to confer population-level benefits. So in the way that they will reduce the overall sort of burden on the healthcare system, overall burden on society in terms of number of infections and severe infections that results in morbidity and mortality. But we really need them to be taken up widely by as many people as possible to really maximize the benefits of these absolutely fantastic vaccines. I'm a data nerd, so a lot of what this presentation will talk about is how we track and monitor vaccine uptake. One of the main ways that we do this or the main ways our local health authorities do this is through the use of immunization information systems. So these databases called IISs are used by local health departments to collect and store data about vaccination events. It recognizes that people receive vaccinations from a variety of places. This could be a hospital or a doctor's office or an urgent care or a pharmacy. In the early stages of vaccine rollout for COVID, there were pop-up clinics in all sorts of places, mass vaccination centers that were locations where we didn't traditionally provide vaccines, but we took the approach early on that any door is a good one for someone who is trying to get a COVID vaccine. And at every single sort of point of entry into this system, there's a record of the vaccination that's done that gets reported to our local jurisdictions and immunization information system. And across states, immunization information systems include a core set of variables, mostly related to patient characteristics, so who got vaccinated, and administration event sort of related characteristics. So this records things like the lot number for the vaccine, the arm that it was administered in, any side effects that were observed immediately after administration, dates of all kinds. Really helps us keep a good track on where vaccine doses go when they're purchased by the state or federal partners and distributed out to sites to provide them. This is the information that comes back to the local health department to understand who got what vaccine and where. And our local immunization information system here in Rhode Island that's maintained by the Rhode Island Department of Health is called RI-CTR. It's the Rhode Island Child and Adult Immunization Registry. Immunization information systems, in addition to serving as an important way for health departments to track uptake of vaccines, there's a bit of two-way information sharing in that patients can request their information from the immunization information system, usually through their healthcare provider. Our authorized healthcare providers that are the ones that provide vaccines that are provided by the state can run reports on patients under their care to determine who's had which vaccines and who hasn't. So this is a really helpful tool for also guiding clinical practice or quality improvement outcomes to really understand who's getting a vaccine and who's not. In Rhode Island, our information about vaccination events has to be transmitted to the health department digitally within 7 days of a vaccine being given. So it's a pretty up-to-date database, generally speaking. And most states have all states have an immunization information system. Many of them have the required sort of core elements that the CDC requires. And I'll talk about what those elements are in a second and what that lets us do. Now, the Rhode Island Child and Adult Immunization Registry is a really important tool because it allows us to estimate vaccine coverage, which I define here as the proportion of eligible individuals who have received a recommended vaccine. And to ensure that all Rhode Islanders benefit from highly effective vaccines, we use the information contained in these databases paired with information on the sizes of various populations and subgroups in Rhode Island to understand how vaccine coverage varies by age, by sex, by race and ethnicity, and by location of residence. Understanding these patterns of difference by location of residence has been a really big part of my team's focus in aiding the Rhode Island Department of Health in responding to COVID. It's not work that I will be discussing today, but on an ongoing basis, my team maps out the locations of all people who have received COVID-19 vaccines, including our updated booster shots that are coming out this year, and track areas in the state where uptake is lower than we would expect by chance, or otherwise where uptake is lagging behind state levels, so that we can really focus our efforts on people who most need vaccines. We have this information kept in a publicly available dashboard so that our partners at the health department and their partners out in the community can regularly access this information and understand where people need to kind of focus their outreach efforts to get more Rhode Islanders vaccinated. You can learn more about that work separately at signal-ri.org. Immunization information systems are great because they capture a lot of very detailed information that, as an epidemiologist, I would want to know about the population of people who are receiving vaccines. So these are a set of, for example, of the core demographic data elements that the CDC recommends and to a certain extent requires be included in an immunization information system that a jurisdiction is setting up. So this includes, because most of these systems were originally developed for childhood vaccines, you'll notice there's a bit of collection of information about parents. That doesn't happen when an adult gets a vaccine, but each patient gets an ID, their name is recorded, information about where they live, their birth date, contact information, some demographic characteristics like their sex, gender, the primary language that they speak, their race, their ethnicity, other things about the person who might be responsible for that individual in the case of a child. And then there's a whole host of elements that are related to administration, like I mentioned earlier, the particular brand of vaccine someone received, the lot number, all of the kind of information about the vial vaccine was pulled from, even what arm or what site on the body and what side it was put in. We collect all of that information. And we've made a lot of headway in increasing sort of the comprehensiveness of these databases. So if you've ever gotten a vaccine in Rhode Island that's recommended by the Advisory Committee on Immunization Practices, your information is likely in this database unless you requested it not to be. But we know that Rhode Island is a small state and people like to travel a little bit to our bordering states. And so we also have data sharing agreements at the Department of Health to be able to get information on Rhode Island residents who are vaccinated in Massachusetts, Connecticut, New Jersey, and New York City, which also increases kind of the coverage of this data system. But as you may start to infer, there's a lot of information we might want to know about people who are and are not vaccinated that's not captured here. So I can compare vaccine coverage by age, by sex, by race, ethnicity, by where somebody lives. But as was mentioned earlier, I'm a social epidemiologist. I'm interested in generally the neighborhoods that people live in, but also where we work, where we go to school. And so I have a pretty strong interest in understanding how health outcomes vary by occupation and by industry, and understanding how we leverage workplaces to promote the public's health. And there's no information here on what someone's job is or what their occupation is. So that kind of information is missing. And when looking at vaccine records by themselves, I don't have a good way of understanding, whether healthcare workers are taking up vaccines in large numbers in the absence of a mandate, how well protected our food service workers are. And so I need other information to be able to answer these questions. And so a resource that I was able to leverage as part of this work, thanks to the support from Advance-CTR, was our Rhode Island's data ecosystem, which is a database, a large database and data system that's maintained by our Executive Office of Health and Human Services. It's a really unique resource here in Rhode Island that I highly recommend people consider using in their public health and clinical research. It consists of a couple sort of phases where all sorts of human services agencies here in Rhode Island are contributing individually identifiable data on who's using their services or what kinds of information gets reported to them. So for example, the Rhode Island Department of Health contributes information about routine vaccines, about vital statistics events like births and deaths. There's some healthcare claims in there from the state Medicare program. And the one additional sort of data stakeholder that I'll highlight today because it's relevant to today's work is the Department of Labor and Training, who contributes regularly information from our quarterly census of employment and wages, which helps us understand who's employed where and how and what they earn in a given quarter, unemployment information, temporary disability insurance, all of those sorts of claims. They're all put together in sort of a data lake where there are processes for matching individuals across data sets based on protected individual information, like their name, their date of birth, or their social security number. A fantastic team at the Executive Office of Health and Human Services works through all of the database architecture to be able to link these things on a secure side, where it's just limited to the ecosystem tech team. And they link those things all together to a new ID number that's unique to the ecosystem that allows you to identify the same individual across data sets without being able to identify that person's name, that date of birth, that social security number. So it allows for data combinations and data sharing for researchers and for state agency partners to gain access to information that other agencies hold under their purview that they wouldn't be able to otherwise access. And it does this all in a way that preserves people's privacy and confidentiality, which is a really important thing for ethical kind of human subjects research. So this particular research was aiming to understand how disparities in COVID vaccine uptake might be explained by differences in working conditions, in particular, what kinds of jobs people have. And this is leveraging the ecosystem, which takes data on immunizations from the Rhode Island Child and Adult Immunization Registry and links it with employment data from the Rhode Island Department of Labor and Training. And in this particular set of analyses, I'll be covering a period of data that covers vaccines administered as of the second quarter of 2022. So this covers the beginning of our vaccination campaign all the way through to when our large state mass vaccination sites closed. So it really covers the period where the bulk of people received their first doses and even some of their first boosters. And so I'm drawing conclusions about kind of early uptake of vaccines or the first round of vaccine uptakes, but obviously we have newly formulated boosters and our recommendations have changed. So towards the tail end of the next 7 minutes, I will cover sort of what this all means for vaccine rollout now. Altogether, the ecosystem was able to provide me information on just shy of 450,000 individuals who are employed by over 37,000 employers over the 2-year period here in Rhode Island. As no surprise to many people, our largest industries here in Rhode Island are healthcare and social assistance, accommodation and food service, and retail trade. These are the largest numbers of employees who are employed in these industries. Most employers are small firms with fewer than 20 employees, but just a small fraction, 3% of those employers are large firms with 100 or more employees. The bulk of our employees are employed by very few large employers. And also to give you a sense, the DLT data also provides me information on wages earned over this calendar period. And employees earned a median wage of about $51,210 over the study period, which is about 7 quarters worth of wages, just shy of 2 years worth of wages. First thing that we can conclude, we can now calculate vaccine coverage by industry and even down to the workplace level if we really wanted to, or by the employer level if we really wanted to. And the main conclusion is that vaccine uptake varies widely by industry, because we now have information about people who were and were not vaccinated all within the same industry. You can see that there's a couple high uptake industries where the vaccine coverage was over 80%. This is likely an underestimate because some vaccines at federal facilities, for example, like the VA, are not included, that were administered at federal facilities are not included here. The data sharing agreements with other states were not as complete at the time this extract was completed. So these vaccine coverage estimates are likely a little bit higher. But our healthcare and social assistance and our educational services are really our two highest uptake industries. We would expect healthcare workers to be highly vaccinated, because they are most likely to come into contact with people who actively have COVID, but two, they were subject to a mandate early on in our vaccine rollout. Educational services, similarly, there was a high emphasis on being able to keep our schools open and functional once we reemerged from our stay-at-home order period of the pandemic. And so educational services workers, our teachers in particular, are high uptake workers. But then there's a couple industries that are much lower uptake, where at least more than half of people took up a dose of a COVID vaccine, but they're still much lower than these high uptake industries. The sort of bottom of our list include construction, agriculture, forestry, fishing, hunting, accommodation, food service, and Rhode Island's smallest industry out of all these categories, mining, quarrying, and oil and gas extraction. Across industries, so I started to try to understand sort of the racial ethnic composition of the labor market and how that's stratified into low and high wage labor, as trying to understand how people's material circumstances impact their chances of taking up a COVID vaccine. And so this graph here shows that across industries, vaccine uptake is significantly lower among people who earned less over this 2-year period. Sort of a no-brainer here, but you see this very clear dose-response relationship between the decile of wages earned during that period, where our lowest earners, fewer than half of them, got at least one dose of a vaccine, whereas nearly 90% of the highest earners got a vaccine. And so to be able to sort of look at this along a joint axis of race and wages and industry, I'll provide you with a couple kind of key takeaways. It's that first, vaccine uptake is highly variable across industries, and across industries, vaccine uptake is lowest among workers in the lowest earning group. The workers that are in that lowest earning quartile account for over 40% of all workers that are employed in accommodation and food service, arts, entertainment, recreation, retail, trade, and agriculture, forestry, fishing, and hunting. And in these particular industries, in this lowest wage category, Latino adults are overrepresented in low-wage work in most of these industries. So we might explain these findings by understanding what kinds of benefits are provided to people who work in different industries. Industries with a disproportionate number of Black and Latino workers who are earning low wages have poor access to unpaid and paid leave and employer-provided health insurance. This is a chart here that gives you a sense of access to some of these benefits across industries. Notice that our vaccine coverage was much lower in our group that was engaged in construction. They have some of the construction workers have some of the lowest access to paid sick leave nationally. Our accommodation and food service workers similarly also have poor access to sick leave. And this is all really important, right? So most of our evidence about what works to promote vaccine uptake in workplaces is really limited to healthcare workers during seasonal influenza vaccine campaigns. And most of the evidence base recommends providing clinics on site, providing clinics with flexible hours, and providing time off to deal with side effects. This is often done in healthcare settings to get healthcare workers to get vaccinated. But now, with these sort of descriptive findings in hand, I'm really focusing sort of the next stage of this research on understanding what these kinds of vaccine promotion efforts in workplaces might look like in industries that have low uptake, where the workforce is highly dispersed. So construction workers, for example, might all work for the same company, but be split across, anywhere from 10 to 20 job sites in a given day. They're not all going to a central location to check in, like all hospital workers are all in the same building, at some point during their shifts. And also for a lot of these these parts of our workforce where the ability to take time off for even personal circumstances or to deal with vaccine-related side effects is not possible or not available. So what would it look like to work with employers to provide extra time off for their workers to get vaccinated is sort of a next stage of this work. These are insights that we draw from our first round of vaccines. We're at a point now where we're asking people to get one annually. and vaccine coverage is going down, not up at this point. We're at a much lower uptake among sort of working age adults for this current round of vaccines that just became available compared to the first round that were made available in late 2020, early 2021. So it's work that kind of has high relevance as we continue to grapple with the COVID pandemic. Kind of to close, I want to thank the funding source here from Advance-CTR that allowed access to this data source, team at EOHHS and its respective data stewards, the Department of Health and Department of Labor and Training that okayed this data linkage, and also to my mentor on this award, Megan Reaney, who helped kind of guide me through the process here. And with that, I'll take questions. Hopefully I'm right on time.
Thank you, Will. Really fascinating. And we're very proud to have sponsored you on this project, and looking forward to some perhaps further collaboration as we develop the COVID sequencing database that is being pursued right now with the biomedical informatics group. One question I have would be, how does to what extent do your studies so far match or align with other studies at a national level, or in other states or regions that have gone to at least some effort to kind of explore these questions?
Yeah, so it's been surprising to see that our understanding of occupational patterns in most COVID-related outcomes other than death is pretty limited because of availability of data. We normally have the health data in one place and the workplace data in another, and it's very rare that there's a resource like what we have in Rhode Island to bring them together. Most of our investigations about occupational patterns in COVID mortality use the fact that someone's usual occupation is on a death certificate. One of the sort of most newsworthy papers to come out of that line of investigation came from the state of California, which was able to look specifically at specific job titles, even in relation to kind of COVID burden. And it generally tracks similarly. Healthcare workers are disproportionately impacted by COVID-related burdens, given the nature of their job in taking care of patients with and without COVID. And many of them were subject to vaccine mandates, so their uptake is high kind of across the board. Across the country, uptake is low in construction, in food service, in some of these jobs that are lower wages, have less access to paid sick leave and other kinds of benefits that are health promoting. Mortality, the highest mortality after healthcare workers in that California study was chefs in restaurants. Many of these jobs are by design in-person employment, can't be done remotely, require face-to-face interaction with either other coworkers in close quarters or with members of the general public. And we've really relaxed a lot of our protections for those workers in their workplaces during COVID surges. And so what we see in Rhode Island tracks generally nationally, where some of our industries are smaller, like we don't have as large of an agricultural industry as some other states do, but we've got plenty of food processing plants. Think of all of our seafood packaging plants at Quonset. Their experience is very similar to what we see in like poultry farms in the Carolinas, for example. So it's generally a very consistent thing. The way the US labor force is structured in Rhode Island is very similar to how it's structured in other places.
Microcosm.
Yeah.
Okay. So another thought I had was, to what extent has the idea of mobile clinics, or basically a van that goes to a work site and or to a strip mall, and where there are a number of small restaurants and things like that, I would clearly there are economical challenges with that, but I'm thinking along the lines of what I think has been done in California and some other places. It's sort of using the barbershop approach and sending pharmacists and so on to take blood pressure measurements and so on to at barbershops where the target population that's a meeting place, the social sites of interaction.
Yeah, and I mean, in Rhode Island, since we started vaccinating people against COVID in December of 2020, there's been vaccines offered at close to over 1,000 different locations. And many of those are the retail pharmacies and the doctor's offices that we think of. But we've brought, I say we, because I think of myself as part of the health department team that helps kind of implement all of this. We've brought vaccines out to housing developments where people can get vaccinated in their homes in large quantities. We've brought them to many large employers, many of our large manufacturing sites, many of our large sort of food processing plants. We've had pop-ups at restaurants, community centers, churches, you name it. We've kind of offered vaccines wherever you can imagine. You know, there were days where we were giving vaccines at Yield English Fish and Chip in Woonsocket. Like, we've probably name a place we've put a vaccine clinic there. We were giving out vaccines at Dunkin' Donuts. You know, we were saying no door was a bad one. What makes it challenging now as we're trying to get people vaccinated with these new doses is that our public health emergency declarations have expired. Lots of otherwise unobligated COVID funds have been rescinded in budget negotiations. And so our infrastructure to be able to bring vaccines, meet people where they're at, is much, much lower. We've got a federal bridge program to cover vaccines for people who are uninsured. Rhode Island has a state supplied vaccine provider program so that the state buys all the vaccines on behalf of all the health providers and provides them out to the local clinics. And so that means that vaccines have to be offered at no charge at the point of administration. So it gets rid of some of those barriers. But now we're at a point where we're saying, if you can get into a doctor's office who's taking a patient, or you can get to a pharmacy, those are your only options. The funding available to get clinics popping up in places like in workplaces is a little bit harder. There's still the option, absolutely, for employers to request those things from the health department. Many large employers will do clinics on site. Think of places like FM Global and Fidelity that have these like corporate office campuses in Rhode Island. But I think, just as we've seen in the general public's view of COVID, employers are kind of tired of thinking about COVID. And so there isn't that sense of like, let's reach out and proactively offer this to our employees. And part of what my work now is looking to do is how to kind of reinvigorate people's interest in all vaccine preventable illnesses, because I'm sure we have similar patterns of uptake for flu vaccines and other sort of things we ask people to get regularly. And so the challenge is now in doing this with a reduced budget that we significantly reduced budget compared to what we had 2 years ago.
One last quick question. I don't think you've mentioned misinformation and the impact of misinformation and social networks. To what extent do you think that there might be a correlation with the wage level as well?
I mean, I'm sure they're all tied in together. So, low vaccine coverage is a function of people who want to get vaccinated not being able to, and people not wanting to get vaccinated to some extent. And so what I study, it's all sort of mixed up into one. COVID is a time where we're seeing the scientific process happen in real time in a way that the general public hasn't always gotten to see. Means we correct ourselves, we deal with uncertainty, and that is a ripe ground for misinformation. I think to some extent everyone is vulnerable to some amount of misinformation, but among low-wage workers who don't see a lot of benefit from a lot of our systems, they don't get paid time off, they don't get working conditions that are responsive to their needs. Why would they want to trust a message from a government authority when there's no regulation sort of keeping their workplace in check and helping them provide for their own needs? There's definitely a need for campaigns to combat mis and disinformation in workplaces also, just as your need to make vaccines available as well.
Thank you so much. Thanks again for a very fascinating presentation, and good luck with your further analysis, and look forward to those publications. Your work. All right, so in the last minute we have here, I just wanted to remind everyone out there in the audience that the next seminar is scheduled for November 9th, and that will be Jake Curtis discussing his work on novel drugs for care of severe malaria. And just in general, please keep an eye on the Advance RI-CTR newsletter for further announcements and updates and exciting opportunities moving forward. So with that, we'll close today's seminar presentations and discussion. Thank you.